In this video, I will introduce the concept of intention to treat analysis. Now, randomized controlled trials, or RCTs, often suffer from two major complications, either non-compliance of the subjects to the treatment protocol or missing outcomes. In other words, data is not available due to either subject dropout or data collection issues. So one potential solution to this problem is a statistical concept called intention to treat. And so the objective of this presentation is to give a basic understanding of the intention to treat concept. And with this objective in mind, this presentation will review the intention to treat analysis principles, the background, the theory, with special emphasis on the need to do this, the application of this concept, as well as the pros and cons in using this particular technique. So first, let's define intention to treat analysis. So when we think about intention to treat analysis, the classic definition is we're doing an analysis, whether it's a t-test or an ANOVA or any kind of statistical analysis in which we're comparing group responses to an intervention. ITT analysis is used to include all randomized subjects in the groups to which they were originally randomly assigned, regardless of their adherence with either entry criteria, the treatment they actually received, and regardless of subsequent withdrawal from the treatment or deviation from that protocol. So in other words, intention to treat analysis includes every subject who is randomized according to their randomized treatment assignment. So it basically ignores non-compliance or reduced compliance, any protocol deviations, withdrawal, and anything that could happen after randomization. So kind of the classic description of ITT analysis is once randomized, always analyzed. So what intention to treat analysis tries to do is tries to give kind of a holistic picture of how people will typically respond to a treatment in kind of a non-perfect world. In a perfect world, obviously everyone would be perfectly compliant, no one would withdraw, the protocol will always be applied perfectly. But in situations in which that's not the case, which happens more often than we'd like to admit, we still want to be able to analyze that data to reflect what is really happening in the study design. So intention to treat analysis is designed to do that for us. So when do we use intention to treat analysis? Well, again, performing randomized controlled trials to study the efficacy of a treatment intervention, we can very often have two possible complications that might occur. The non-compliance with treatment protocol or poor compliance with treatment protocol, or there might be missing data or missing outcomes due to withdrawal or other issues. Now, intention to treat analysis allows us to compensate for that. And it's become a required portion of analysis based upon many accepted methodological guidelines. The consort standards, the consolidated standards of reporting trials, those guidelines require some level of intention to treat analysis. If you're doing pharmaceutical research under the purview of the FDA, they require intention to treat analysis, and many other guidelines that are out there for clinical trials encourage or require the use of intention to treat analysis. So there is kind of an overriding need or requirement to do this, but we'll talk a little bit more in depth later on about kind of different ways we can think about when it's really necessary and when it's really important for us to apply the principle of intention to treat analysis. So when do we use intention to treat analysis? Do we always have to do it? Well, some of it depends on what your study goal is. And when we think about what you're trying to accomplish in a study, we can think of it kind of having two general goals. The first being a pragmatic study goal. And this is where we're trying to identify the usefulness of a treatment in a real-world situation, in a clinical practice. So knowing that studying human subjects is pretty messy because humans, we can never really predict how they're going to respond, or we can never really predict how they'll respond within a study situation. And we accept that. We accept the fact that it could be messy, there could be noncompliance, there could be withdrawal, there could be treatment or data collection mistakes. And so if we're okay with that and we're accepting that, then our goal is pragmatic. Okay. Now, if we have an explanatory goal, in other words, we really want to be able to isolate and identify the biologic or the physiologic or psychological effects of a treatment. In other words, we want to study what would happen when applying a treatment in a perfect world, kind of more of a laboratory setting, then that would be more of an explanatory goal. So if we really want to be able to identify what a treatment really does to someone, if everything is the way we want it to be in a perfect world, then that would be an explanatory type of study goal. So part of what you have to think about when you start thinking about, do I need to do intention to treat analysis, is what's your study goal? Is it pragmatic or is it more explanatory? So if your goal is pragmatic, then intention to treat analysis should be part of your overall analysis. And so that's what intention to treat analysis helps us do. It helps us further clarify a pragmatic study goal. Now, if your goal is explanatory, then we're assuming that in order to really understand the effect of the treatment, we need to have perfect compliance. And so we enforce this perfect compliance by excluding any non-compliant subjects from the analysis. So anyone that's non-compliant or anyone that withdraws partway through the study, we just exclude them. Because if they didn't receive the full treatment, we can't really study the true treatment effect. And so we exclude them from the analysis. So that's one thing to think about as you start to think about, do I need to do intention to treat? Well, it depends on what your study goal is. Now let's talk a little bit about the pros and cons of intention to treat analysis. And so the advantages of using intention to treat is that it tends to kind of counter overly optimistic results of intervention efficacy. So if we have that kind of explanatory idea, we're only studying people that have 100% perfect compliance, that can actually overestimate the effect of the treatment. Because if we counter in what happens in the real world, when people are less than perfectly compliant, when people drop out, when things go wrong, that could show us what the true real effect might be of the treatment. So explanatory studies tend to can have the possibility of overestimating the true treatment effect. So intention to treat analysis can help us reduce that. It gives us a little bit more of a conservative idea of what the treatment can do, and therefore it can reduce type 1 hypothesis error. In other words, we're not going to reject a null hypothesis that we should be accepting. Okay, another advantage is it improves the quality and validity of the results. Okay, by making sure that we are accounting for all the possible things that could go wrong, and we can still see a treatment effect, then that strengthens our interpretation to show that we've accounted for all of the possibilities that could go wrong. So that strengthens the validity, the quality, as well as the generalizability of our study results. Intention to treat also really reflects what happens in clinical scenarios, because it admits that there is non-compliance and there might be protocol deviations, because in the real world sometimes patients forget to take their medication, sometimes patients forget to do their treatment, and so this really reflects what happens in the real world. Another advantage is that intention to treat maintains the advantages we had of the original randomization. So it helps maintain any prognostic balance generated from the original random treatment allocations. So it allows us to maintain that, because if we start excluding people, that could be being done in a non-random way. And so when we do that, that tends to remove the benefits of the randomization. So now we end up with maybe some biased samples. Another strength is it also helps provide an unbiased estimate of the treatment effect. So if non-compliant subjects and dropouts are excluded from the analysis, it might create some differences among the treatment groups, and therefore they might respond to the treatment differently. But if we maintain an unbiased sample, then we have an unbiased estimate of the true treatment effect, whether it's effective or not effective. And also, subjects might be non-compliant or may drop out from the study due to their actual response to the treatment. If they have a negative response to the treatment, in other words, a harmful response to the treatment, then that might be why they dropped out. So if we exclude them, we won't be able to account for that response to the treatment. But if we include them in intention to treat analysis, we can see the fact that there are some subjects that did not respond well. Now, intention to treat analysis also preserves the sample size because if non-compliant subjects and dropouts are excluded from the final analysis, it might significantly reduce our sample size, and that leads to reduced statistical power. Also, intention to treat limits inferences based upon these kinds of subgroups of patients in the trial that might develop. If we're excluding subjects, we might develop these kind of subgroups that are somewhat arbitrary, and it also emphasizes accountability for all patients. And so because it limits biases, our inferences also won't be biased. So it minimizes type 1 error due to this more cautious approach, and also allows for greater generalizability. So the advantages of intention to treat are significant, are many, especially if our goal, again, is a pragmatic analysis. Now, the disadvantages of intention to treat, and there are a few, and there are some valid arguments against intention to treat. And the first would be, again, if you're doing an explanatory study, then you really don't need to do intention to treat, or you probably shouldn't do intention to treat. So first of all, if a subject who actually did not receive any treatment is included as a subject who received treatment, then it really doesn't tell us anything about the efficacy. So if we have a subject that received only one treatment or no treatments, and we still include them in the analysis, that doesn't really help us understand the true effect of the treatment. Okay. Now, in intention to treat analysis, the estimate of the treatment effect is generally a little bit more conservative because of dilution due to non-compliance. So we might actually underestimate the actual treatment effect. So this could lead to some type 2 error. Also, we may create some heterogeneity in our sample because if non-compliance, dropouts, and compliant subjects are mixed together in the final analysis, that might actually, create some additional variance in the outcome data, and also create some heterogeneity in our sample. Okay. Also, the endpoint data or the outcome data might differ significantly among non-compliant subjects and compliant subjects. So this might create some very large variance in the outcome data, and so interpretation might become really difficult if a large proportion of our subjects are non-compliant or maybe got the wrong treatment. Okay. So it also is going to estimate participant response versus measuring actual response. So if we do a technique called multiple imputation, or if we do something called last value carried forward, this is really estimating how the subject might respond, and they may have actually responded very differently than how we estimated them to respond. And so again, this could create some type 2 error where we're actually underestimating the actual treatment effect. Now, in order to actually apply an intention to treat analysis, we need to think about the fact that we have a set of data. We've got data probably set up in groups, like a treatment group or a control group or multiple treatment groups. So we might be doing a t-test or an ANOVA of some kind. And so we basically run those techniques the same way we would without doing an intention to treat analysis. What the intention to treat analysis is really doing is including certain data points that maybe wouldn't have been there, or including subjects that maybe have been non-compliant. So it's really just a matter of selectively choosing who should be included in the analysis and who shouldn't be. That's really what intention to treat analysis is. So as we think about some of these different issues and how we can apply intention to treat analysis, the first issue we'll talk about is non-compliance with the treatment protocol. So either the subject did not receive the entire treatment, or maybe had limited treatments that they were subjected to, or maybe they withdrew before the entire treatment was completed. So if our goal is pragmatic analysis, then we definitely want to include those non-compliant subjects in our t-test or our ANOVA or whatever we're doing. So we're going to include those subjects' outcome data, presuming they have outcome data. So why would we do that? Well, because the compliance or non-compliance occurred after the randomization. So if we exclude them, that really won't give us an idea of how different people with different levels of compliance might respond to the treatment, and also might introduce some bias into our groups. So also attempting to account for non-compliance by excluding non-compliant subjects can bias the sample as well as our ability to see the true treatment effect. And in clinical practice, some patients are not fully compliant. So to really get an idea of how things might work in the real world in a clinical setting, we need to accept the fact that some patients might be non-compliant. And so this again gives us a better idea of the holistic response that we might get to a treatment. Now, we can also do kind of an explanatory analysis. So if our goal is pragmatic, but we also want to try and understand perhaps the biologic effect of the treatment with full compliance, we can still do an explanatory analysis. So what we do is we pull out a subset of the subjects that were fully compliant. In other words, the subjects that received the full course of treatment and received every intended treatment. When we do this, when we pull this subset out, this is known as a per protocol analysis. And so these are just the subjects that receive the full treatment. Now, we can do this and try and get an idea of the biologic response, but there's a strong possibility of bias. So the people that receive the full protocol, there might be something very different about them than the people that didn't receive the full protocol, especially if we have a high withdrawal rate because people aren't tolerating the treatment very well. And so there might be something very unique about the people that receive the full treatment. A good example of this is some research that was done several years ago on different types of diets, comparing like a low-fat diet to the Atkins diet. And a large proportion of the people on the Atkins diet didn't complete it. In other words, they dropped out before they finished the full treatment. So the people that were left that actually finished the Atkins diet, they probably had a weight loss that was going to be higher than the typical person was going to have because they tolerated the entire protocol. And so there was probably some strong bias in those people that finished the entire Atkins protocol versus people that didn't. So there is that strong possibility in this subset of bias. So a lot of times what we'll do is we'll use a per protocol analysis in conjunction with the intention to treat analysis to try and a little bit better understand what the true treatment effect is. So if people respond really well in a per protocol analysis and they respond similarly in the intention to treat analysis, then you can be pretty sure that you've got a good treatment. You're going to have a treatment effect no matter what situation you're in. But if those two analyses are very different from one another, in other words, the per protocol people do really well by the treatment, but the intention to treat analysis group does not do as well, then that goes to show you that the treatment might not really be doing what we think it's doing. So we can very often do these analyses in conjunction with one another. Do we have to do them? No, we don't, but we can. Okay, so that's typically how we deal with the non-compliance issue, and there are certainly obviously pros and cons to either one of those situations. Now, dealing with missing data. If we're going to do intention to treat analysis, again, and we've got missing data due to either withdrawal or some data collection issues, why should we try and include those people that have missing data? Well, again, if our goal is pragmatic, then, or we're very concerned about trying to preserve our sample size, then we're probably going to include those withdrawals. So again, withdrawals that occur after randomization might be due to the treatment. So our ability to understand the true treatment effect, some people do really bad on it and drop out, some people do okay on it. We want to be able to see both sides of that experience. And if we exclude people that dropped out because they had a bad experience, we'll miss that. We won't be able to see that negative treatment effect or that detrimental treatment effect. And again, if we exclude subjects, we could be introducing some bias. You know, one of the rules of thumb is if we've got a greater than 5% missing rate, in other words, more than 5% of the sample has missing data, that could indicate some bias. And so we're probably going to want to do an intention to treat analysis. In other words, somehow include those subjects. If it's less than 5% and you're not concerned about doing intention to treat, then you shouldn't feel bad about excluding those subjects. But intention to treat, replacing missing data is a possibility. Okay, so we have basically two strategies that you'll typically see in large randomized controlled trials in order to deal with missing data. One of the first is called last observation carried forward. And this is where, especially if we're doing repeated measures design, where we might have two measurements on a subject, but we don't have the third measurement on that subject. So what we do is basically take what their outcome was on the second measurement and carry that forward to the third measurement. It's very easy to do. It doesn't take any additional calculation. But what this possibly does is results in an underestimation of the treatment effect. So we're basically saying if I carry forward what happened from measurement point 2 to measurement point 3, I'm saying that between point 2 and point 3 there was no treatment effect because they have the same value at those two measurement points. But the problem is the person might actually have improved over the course of that second time period. And so their actual outcome data point may have been very different than that carry forward data point. And so that could actually underestimate the true treatment effect and result in a type 2 error. Another possibility is multiple imputation. Now this is a more difficult way to replace missing data. And in a nutshell, what happens here is we create these regression equations that then estimates what the likely outcome would have been if the person would have continued in the treatment and wouldn't have dropped out. So it develops an estimation of that likely outcome value. Now, this is probably going to more likely represent what their true response would have been compared to the last observation carried forward. So at least we're going to see some effect, and obviously it's not going to completely, it's not going to give us a perfect value exactly what that person would have, how that person would have responded, but at least it gives us a decent estimate of that. And so that is another possibility. Now a third possibility, and one that is most likely not going to be used in larger randomized controlled trials, is known as Winsorizing. Winsorizing is where we take a value and replace it with the mean or a similar value that other subjects may have had. That tends to, again, underestimate the real outcome and is probably not recommended in larger trials where we've got large numbers of subjects that might have that occurrence. Now, when we do intention to treat analysis or per protocol analysis, it's very important that we report that we explain what we did in detail. And so, if we're going to do an intention to treat analysis and a per protocol analysis, we might have two t-tests that we do, one for the intention to treat and then one for the per protocol analysis. So it's important that we report each of those analyses that we do and identify them. Which was the intention to treat analysis outcome and which was the per protocol analysis outcome. So very often what people will do, and the consort guidelines recommend this, is we create a flow chart that shows how many patients we originally started with, how many received the treatment, how many did not, how many dropped out during the course of the treatment, how many missing data points do we have. And so this is a great way to explain how we ended up doing our intention to treat or our per protocol analysis. And so this is, as I mentioned, a really good way to be able to kind of help people visualize exactly how many subjects were analyzed in each of these different analysis types. So this is a very important aspect of intention to treat, is being able to display exactly how you got to the intention to treat analysis. So to summarize or to conclude this presentation on intention to treat, randomized controlled trials often present subject compliance or missing data issues. And so intention to treat gives us an approach to kind of mitigate or at least account for these effects. When we do intention to treat, however, we might tend to have a more conservative interpretation of the treatment effect itself. Also, combining compliant and non-compliant subjects in intention to treat may introduce some bias, as well as give us large variations in our outcome data, which again tends to maybe make us underestimate the true treatment effect or the true treatment response. But good design, very diligent, well-controlled data collection, and doing as much as we can in our design and procedures to minimize subject non-compliance may actually help us preclude the need for intention to treat. So, if, again, in a perfect world, we'll have perfect compliance, no dropout. But if we can do things to the best of our ability to minimize that, then that really does minimize the need for doing intention to treat analysis. So hopefully you enjoyed the presentation, you learned something, and hopefully this will be useful for you as you move forward in your own research.